Hello, hello. Good afternoon. Good afternoon. How is everyone doing today on this hot day here in Delaware? Hope you are doing okay in your area as well. Um, it's Wednesday, September 6th, and for those who have birthdays today, happy birthday to you. We are experiencing some really hot weather here in Wilmington, Delaware. And so if it's hot where you are, in whatever area of the country you are, please let me know how you are dealing with this heat. And so we want to make sure that you are staying cool. We want to avoid any possibility of heat stroke. So you may want to take any precautions that you need to do to stay out of this hot weather. If you have to go to the doctor, make sure that you go in and get out and stay cool. If you have any elderly people who are living alone and may not have air conditioning, you may want to check on your neighbors, because it's also important that the elderly receive that care. Oftentimes we forget the fact that they may not have the same amenities we may have, or you may not have. So if it's a way to stay cool and your apartment or your house doesn't have that ability to cool it down, maybe you can get someone to take you to the mall or the nearest place that's a senior center or any kind of neighborhood community center where you can participate in some indoor activities. And so oftentimes it's important to not necessarily think about just ourselves, but to others. So I welcome all of you for joining this morning. It's Dr. Velma Scanterbury, and I'm the medical consultant for Dialysis Patient Center Educational Center. So we're here today to talk and to have a chat. So I see one person said it's warm here in California, so she's loving the pool. There you go. Make sure that you stay hydrated as well. For those of you who can drink, even if you are on dialysis, you may want to make sure that this is a good time to freeze some of those grapes, and oftentimes you can stay hydrated by eating some frozen fruits. And it's also, September, so you must be thinking about vaccinations. Should you get your flu vaccine coming up soon, because we're getting into the flu season. And also, someone said RSV. What's the difference, and can you get the immunizations at the same time? I know you remember that during COVID, after COVID and last fall, as we were getting into the flu season, we were doing many webinars on getting your vaccines. And if you're getting your COVID vaccine, go ahead and get your flu vaccine. That is what I did. I think we got it in different arms because I didn't want, some people want both on one side, but you can get both at the same time. I know initially when COVID came out, they were advocating perhaps wait between one and the other. I remember some of the initial testing questions were if you had a flu vaccine or you had any kind of vaccines right before your COVID vaccine, that you had to wait at least 2 weeks. But now that has gone away, and we learned that your immune system can really tackle and handle two vaccines at the same time. So certainly we want to be able to, we know that there is a new monovalent vaccine that's coming out hopefully in a few weeks, and that will become available for the new strain of the COVID vaccine. And so we're encouraging people to make sure so far the FDA and the CDC have not set up any regulations as to who will get it. We know that those who are immunocompromised and those who are over 65 generally are usually subject to get vaccination within the first groups of people. So you as a dialysis patient or transplant patient are considered immunocompromised, and therefore you will be in that group that will be able to get vaccinated. But remember that if you are high risk, have any kind of autoimmune diseases, on dialysis, post-transplant, you also have to think about the people who you live in the house with you. because they also may not be high risk, but they're living with you. So they are caretakers are there, and so their risk of exposure also puts you at risk. So it's important for them to understand that if it's possible for them to get vaccinated, and one of the things we would tell our patients is if you're a caretaker of someone at risk, you want to make sure you tell that to the physician or the place where you're getting vaccinated, because you may not necessarily fit into the category of at risk, but you are subjecting someone else to your risk. So we often vaccinated those people who were caretakers of those who are immunocompromised, and that's important to know. So whether it's your spouse, whether it's your children, I'm not sure how young, but sometimes the vaccine is approved for over a certain age before it gets to the kids. Or they may start out and say everyone from age 6 months to as old as you are, to any age, no age limit to get the vaccines, just so everyone will get vaccinated at the same time. Because when you put restrictions on who gets it, then people get delayed. Oh, I can't get it this time. Then before you know it, you're forgetting to go get your vaccine. So also for RSV, you want to make sure if you qualify for it to get your vaccine, and there's no harm in getting them at the same time. You may end up with arm hurting. Some people say I'll get both on the same side, so I only have discomfort on one side. So thank you so much for that question. Again, I am Dr. Velma Scanterbury from the Dialysis Patient Citizens Educational Center as a medical consultant. We're here to answer your questions. So thank you so much for joining. GIERDSKE5, thank you for joining and for being here. So let me know if you have any questions, what we can talk about, and we can carry on this conversation. So welcome everyone. We're coming to the close of summer after Labor Day, and I hope all of you had a wonderful Labor Day and enjoyed the holiday and celebrated. Some of you had a delayed dialysis because you couldn't go on Monday, but you ended up going on Tuesdays. But I hope you didn't push yourself to the limit with too much volume on board or jeopardize your ability to be dialyzed. Because sometimes when you have those long stretches, we end up consuming more than we should. And you have to remember that if you're on dialysis, your volume, your dry weight, and what you gained during the time before you return to dialysis, and how much you take off during dialysis is what puts your heart at jeopardy. So you want to be cognizant of your volume gains, and that's very, very crucial, because you don't want to enlarge your heart any more than you have that have occurred by being on dialysis. And so that's very important. So someone asks a question, if someone donates a kidney and later needs a kidney, do they have special privileges? Great question. Actually, I was seeing a patient yesterday who was a previous donor to his sister, and on his medical information he wrote he had a kidney operation, but he didn't say he was a living donor. So I wanted to find out what kind of operation he had on his kidney, and he said he had donated a kidney to his sister. And I said, well, that is a wonderful thing. That is something you would be proud to say. My left kidney was donated, a kidney donor, because it becomes important, because he was now almost 10 years out from being a living donor, had not seen a physician probably in the last 5 years, because he was followed very closely for the first few years and then fell off as he was doing well. But if you have one kidney and or donated a kidney in the past and end up losing your kidney, or it's important to continue to follow your creatinine to make sure your kidney function remains normal, or if it isn't, to know what's coming down the pipeline. But there are a few people who have donated, not a few, many people have donated a kidney and ended up with kidney disease from underlying undetermined, or they may develop hypertension later in life. And so they get special privilege of receiving a kidney. It's best if they can find someone to donate to them, but if they have to get on the list, they will get priority. Children get priority first, those with high antibody level, but as a living donor, you get priority above all other waiting for a deceased organ donor. So you will get priority if you have donated. You get extra points because you gave that gift of life to someone, and so you should be repaid by not having to wait many, many years to get a kidney having donated. So that is a special privilege for any previous donors. And I did have a patient who had been on dialysis as a living donor. Unfortunately, and when she came to be evaluated for a kidney transplant, because her physician didn't know that she should move to the top of the line to say, but not really. She has special privileges to get transplanted. So when she came in and told her, we will get you on the list, but you will be transplanted in a few months, and she was like, oh, I'm not quite ready yet. But yes, so those are things that will happen if you know someone who was a previous donor and lose the kidney function of that remaining kidney. It's important to let them know that. Another question is, if you receive a cadaver kidney from a diabetic, will you become diabetic? No. What we do with patients with potential organs from diabetic patients is that, you remember, diabetes is a disease that can affect many different organs. So there are people who have diabetes without kidney disease. There are people who have diabetes, have eye disease, and have vascular disease, other issues, and may not necessarily have any significant diabetic disease in their kidneys. But if we have a donor who's diabetic, we will biopsy that kidney and make sure that it's usable. You want to make sure that there's no significant major changes or scarring in the kidney from that diabetic donor. What we don't do generally is put a kidney from a diabetic donor into a diabetic recipient, because those the diabetic changes will be accelerated in a diabetic patient. So it wouldn't make you become diabetic because that's from the donor, unless you have risk factors for becoming diabetic. And so the changes in the kidney that you see from diabetes are systemic changes that come because you lack the ability to make insulin. And so after transplant, there is a small risk of becoming diabetic because of the steroids and the anti-rejection medicine. So there are patients who will become diabetic after transplant. And so many transplant programs are now avoiding the use of steroids, which can lead to diabetes. And so we minimize steroids in the post-transplant period. And that becomes very important to decrease your risk of becoming diabetic. One of the things that patients don't understand is, if you have diabetes and you end up with kidney disease, your body excretes the insulin byproducts via your urine, and your kidneys function by getting rid of the insulin byproducts. So you need insulin to control your blood sugar. If, as your kidney function worsens, you are unable to excrete what little insulin your body makes. So if you make only 20% of your insulin is made by your body, and you need that 80% supplemented through insulin products, now with kidney disease or people on dialysis, they're unable to excrete that 20%. So now that 20% becomes 40 or 60% because it's not going away. And you find that you don't need insulin injections anymore. And so people on dialysis will say, I no longer have kidney disease because I don't need insulin. Well, it's because you don't have kidney function to excrete the insulin. And so as you become end-stage renal disease, your diabetes will not be required. You will not be required to be treated as severely as you were. When you get a new kidney and you start making urine and you start having a kidney function, you will excrete that insulin. Then you will find that you need to be back on insulin or diabetic medication after your kidney transplant. So patients feel like the diabetes went away. Well, it just was under control because you were not able to excrete the byproducts of your insulin that your body makes. So I hope that makes things a little clearer. It's not that you're no longer diabetic. It's not just that you will not need to be treated for it because of your kidney disease. And so depending on where you are in your diabetic course of life, depending on how severe your diabetes is, how many medications you're on to control your diabetes, then post-transplant, most of those medicines will need to be restarted and will manage your diabetes again post-transplant with normal kidney function. When we say we are minimizing steroids after transplant, some patients will still need to be, there are different protocols where patients, we give them all the prednisone or the steroids they need to decrease the risk of rejection while they're in the hospital, and they're discharged on a small dose or no dose. But if you had been on prednisone before your transplant for some other reason, you will likely stay on it. If you had a previous transplant and had a rejection, you may stay on prednisone with your repeat transplant. There's some people who come to transplant on prednisone because they also have another transplant in place. Maybe they had a heart transplant or a liver transplant and they were on prednisone for that transplant. Then the prednisone will stay, as well as if you have a high risk of rejection. So if you have autoantibodies or high antibody level, then you will likely be discharged on prednisone because your risk of developing rejection is going to be higher. And so prednisone has its good points and its bad points, but it's also used as in part of the protocols to decrease rejection in those patients who are high risk, such as those with high antibody levels. If you're getting a transplant for the second or third time, more than likely you will be discharged after transplant on prednisone to see how you do. Oftentimes, even the patients who come to transplant with a history of lupus and they have not been able to get off of prednisone because reactivation of their lupus, then with transplant, we don't transplant them until we get down to a minimum dose of 5, and then after transplant, we will continue that low dose that's needed not only for transplant, but to also keep their lupus under control. So different disease processes that a patient may have may cause them to come to transplant on prednisone, irrespective of what we want to do or how we want to treat them after transplant. So yeah, there are some patients who can avoid prednisone, but if they develop a rejection once and especially twice off prednisone, we're going to leave you on that prednisone after we treat you for rejection, because you may need that third drug to keep your kidney going besides tacrolimus and besides mycophenolate. So for most people, 2 drugs is enough, but for a particular group of people, they would need that third drug, which may be a prednisone. So thank you so much for that question, and welcome for those of you who just joined. This is Dr. Velma Scanterbury. I am the medical consultant for Dialysis Patients Citizens Educational Center. And if you haven't gone to the website yet, I encourage you to go to DPC Educational Center and join, because there's so much to be offered on the website. You can learn about advocacy. You can learn about many medical topics. You can see the advantages of those who are ambassadors and what they do and what they're able to do in their own local area. You can often even check to see how many patients are in dialysis in the area you're living. And so that is a very informative website, and make sure you sign up for the newsletter and for anything that's coming out of there. So welcome everyone. Thank you so much for joining. We'll be having this conversation about dialysis and transplantation. We talked about previous living donors, and if they develop kidney disease and need a kidney, yes, they do get priority on the list to get transplanted. And we talked about being on prednisone, and so there's dialysis after transplant. What happens? And sometimes some kidneys that get transplanted in the early days of in the early period after transplantation, you may get what's called a sleepy kidney. And we may use a kidney that we know had a traumatic incident, such as how the person died. If at the time of death it was they were hypotensive, had to be resuscitated. The patient may be 25 years old, but they might have suffered a shock to the kidneys because of major blood loss, the traumatic injury. Maybe they had to be operated on, things that caused them to have a decreased urine output, and the kidneys might have gone into shock because of the incidence of how the death occurred. We will still use those kidneys because they're otherwise healthy, and oftentimes they may not work immediately, and so the patient may need to be in dialysis in the first few days or week after transplant until that kidney recovers in its new environment. Now it has normal blood pressure. Now it has normal flow. And for some patients, they have a kidney and they're a little upset that they're not making as much urine as expected. But then suddenly on day 5, they start making more. At day 6, they're up to 500 cc's, and by day 7, they're on making a liter a day. And for most patients, if you make a liter a day, your creatinine will likely not change, and therefore we will see that you don't necessarily need dialysis. And so we may send you home over the weekend to see how you do. So it's not unusual, based on the age of the donor, to be able to say, this kidney may not work well enough initially, but I'm confident that it will kick in and open up and make urine. So some patients will need dialysis after transplant, mostly related to how that donor died and the underlying factors that led to death, even how long they were hospitalized. Did they need to be resuscitated? Those things, as you drop your blood pressure, your body moves blood away from your body to your brain, so you're going to get less blood flow to your kidneys. But because your body is saying, I want your brain to survive, your kidneys, they'll get better. So for those donors, it's important to understand that, yeah, the kidneys are still good. They're just in a state of shock. And once they're in an environment, they will recover. So we don't want to be wasting kidneys. As you know, right now in our system, we're being criticized as wasting too many kidneys. So we don't want to do that. We want to be able to use those kidneys that we feel are appropriate to be used, and make sure that we have some certainty of a good outcome. Unfortunately, there are often times where we predict the kidney is going to work well, it doesn't work as well as we thought it would, because there's always underlying family history of things that we may not have known that occurred in the life of that donor. And oftentimes, if you have a donor with no family to tell you their past medical history, you may be a little questionable whether or not this is going to work well based on just that one time, or that those two preceding numbers of kidney function that we had at the time of donation. So what can you say to a dialysis patient who's afraid to get a transplant without being pushy? Who's afraid to get a transplant without being pushy? Well, I mean, the question is, why do you not want a transplant? We know that longevity with a transplant is so much better than without our staying on dialysis. So your chances of survival are so much greater long term. Dialysis is only there to, if you know, most patients on dialysis don't have normal creatinine. They have creatinine that remains elevated because dialysis is not going to restore you to normal kidney function. But we know a transplant will get you to as close to normal kidney function as possible. It may not be 1, but it may be 1.5. It may be 1.8. Most people are somewhere in that area. But if you're in dialysis, you're not even anywhere close there. You're mostly 4, 8, 10. So you're still being subjected to the downsides of renal uremia fluid gains. If you're on PD, much better for you. I say look at the risks and benefits of transplantation versus dialysis. Why are you being reluctant? What are your fears? And talk to your doctor about those fears. Discuss and find someone to talk to about what's hindering you from getting a transplant. There are many people who want a transplant but can't get it because they have bad vascular disease. Watch your phosphorus. You want that phosphorus is very important because phosphorus calcium metabolism leads to buildup of atherosclerosis and hard blood vessels, which makes it very difficult to get a transplant if your blood vessels are totally calcified. You may qualify through the workup, and suddenly you have a CT scan showing that your vessels are so poor and so thickened and so calcified that now you can't get a transplant because there's nowhere to connect it to. And all that comes from too much phosphorus in your system. And so it's essential that you look at why you're afraid. I'll be happy to talk to you offline if there's anyone who wants to consider transplant but is afraid of it. Oftentimes as a dialysis patient, you may see others go in for the transplant and didn't come back. They might have passed away or died, and so you got reluctant. But you don't know what the risk factors were. You don't know what occurred. And there's so much to the story that can't be discussed because of HIPAA regulations. But you see the end side. So don't be discouraged. Each person is individual. If we feel that it's not for you, there are many people who come to the table with tremendous potentials for major complications. And I would talk to them about those potential complications and discuss whether or not this is something for you. And it may not be, because dialysis, transplant is not for everyone. But you definitely want to look at the pros and cons, especially if you are being on dialysis for many years, if you have underlying heart disease, what's the status of your heart? If you're healthy and without major vascular complications, then there's probably very little. You may have a clotting disorder. There are people who clotted a kidney first time, second time, and so we say, well, I'm not sure you can get through a third time without clotting because you may have some kind of underlying issue that we haven't been able to really put our fingers on. So it's one person's story is not the other's, and so it's important to have good conversations with your doctor, with your providers, with your support team, because don't be afraid because of what happened to the other person, because their story may be totally different from yours. And every kidney that's offered is not like the previous one. I can take 2 kidneys from the same donor and put them into 2 recipients and have 2 absolute different outcomes because of each person's underlying issues, their heart issues. One person the kidney may work right away, and the other person it may not. Why? Because the environment is different. The medical problems may be different. So it's often, those kind of things are important to understand. So we're coming up on the hour. I thank you so much for listening. It's important to have this information. It's important to know what your questions are when you go to your doctor, or when you visit, or you're sitting there saying, I don't know more about this. I wish I could know more about this. This is where we can really help you with that information. So reach out to me, reach out to our educational program manager, Nancy Scott, and we're happy to provide you with any information that you may need so that you're more informed and you can have a wonderful discussion with your caretakers and your team. So thank you all today for being here. I appreciate your questions. I appreciate your presence, and have a wonderful day and enjoy the rest of your week. God bless. Take care.